Hey, good afternoon, everyone, and welcome to today's learning session. This is Tom Cogswell with the OHA Transformation Center. Thanks for joining us. I'm going to go through some just basic kind of logistics before we get started. Even though we are probably all been on Zoom meetings all day and throughout this pandemic, but you can reach out to myself or Nona Gunn if you have any questions about Zoom, anything comes up technical-wise. We are recording this session, so if you have colleagues who couldn't make it, we'll make sure to share that link. And we'll send out the slides also afterwards. So we are excited to welcome Nancy and Heather here from Columbia Pacific CCO. And just wanted to say a few words just kind of about kind of how we got here. You know, one of the areas our office supports are CCO community health assessments, community health improvement plans. And we always here at our office like to lift up best practices and innovative work going on here. And Joelle Archibald, Innovator Agent for the supporting Columbia Pacific CCO, connected us to Nancy and Heather and the amazing work they're doing and conducted around their community health assessment around 2018. And really, community consumer-oriented way of collecting data and letting consumers provide input about their experience with healthcare. So just excited to share this all with you. We're really excited to hear about this work, and we'll go ahead and turn it over to Heather and Nancy from here.
Thank you so much, Tom, and thank you for inviting us to be here today. My name is Heather Oberst, and I'm a Community Engagement Specialist at Columbia Pacific CCO, and I'm going to be presenting with Nancy Knopf, the Director of Community Health Partnerships for the CCO. And we're going to walk you through our person-centered data collection method that is kind of the backbone of our community health assessment. Take it away, Nancy.
Will do. And I want to start out by apologizing. I can't have my camera on. I'm getting these really interesting notifications, and I don't want the whole thing to freeze up on me, so I apologize for that. But we're excited to be here to share with you a process that we utilized for doing the health needs as one of the components of the health needs assessment for our regional health improvement plan with Columbia Pacific. And just as a reminder to folks that Columbia Pacific CCO is the Medicaid OHP insurance plan for Medicaid members in Clatsop, Columbia, and Tillamook counties. And we have a very large geographical area that we cover, but a rural population, and around 100,000 people total in the 3 counties. Do you want to go to the next slide, Heather?
Sure thing.
Or is it work? Have you gone to the?
I have.
It's frozen up.
That's okay. So talking about the traditional assessments, we do still use the MAP, the Mobilizing for Action Through Planning and Partnerships model by Nacho. And where we're kind of focused today is here in the 4 assessments. Our way of kind of doing this first item, the community themes and strengths survey, and a bit of the systems assessments and forces of change assessments. So kind of, we still do a lot around key health indicators, but just to kind of ground us in what part of the community health assessment process we're talking about today. So one thing that's really interesting about trying to do a community health assessment that I'm sure many of you are familiar with is that both CCOs and the communities that we serve are complex things. And so what we would consider a traditional survey doesn't necessarily always kind of express and honor that that complexity, right? A lot of different measurement processors are really based around things that are simple. You know, A plus B equals C, we put something in, we get something out, you know, but that can be really challenging when you're talking about whole communities and about CCOs, because something that might work in a scenario or for a health problem in 2010 might not work in 2021. And so we can kind of understand things really well in retrospect, but it can make it hard to kind of think ahead on certain things coming down the road. So we focus on person-centered data to kind of help express the complexity that's true in our communities. And so our definition of person-centered data at the CCO is that the community whose habits, opinions, and/or experiences are collected are also informing all phases of the design, development, and implementation of information gathering. The methods of collection are also built to reflect the community's interpretations of their own experience rather than that of the collector. So kind of trying to do our best to take the collector out of the interpretation area of the data.
Hi, I'm back. I'm just calling in on my phone, so I can see the slide deck now, Heather, just as a heads up.
Awesome. So why this matters, why we kind of have honed in on really needing person-centered data is that it supports the translation of the information we get from the community into effective interventions, because we can pinpoint commonalities between stories, or the "this should never happen once" type stories, or the "we should really replicate that as many times as possible" stories. It also allows for weighting or uplifting voices that may otherwise be drowned out by the majority. So looking particularly at communities who are a lot smaller in number, but who may be experiencing disparities in their experience of care or in their experience of community, we can really go in and look at the deep, rich information about what they're saying and weight it against the whole in a little bit more rich of a way. It also allows for respondents to be champions. So when we're doing this with consumers, or we tend to call them members. And they're doing this with us, which means they're going into their communities and saying, isn't it great that the CCO wants to do things this way? They really are going to listen to you. You should be part of this. And that being a champion on behalf of the process increases the trust of the results on the other end. It also shows promise for addressing multiple levels of causality, because we can look at individual cases, but we can also look at the whole and kind of look at everything in between to help improve decisions around intervention. And then we also think that this supports the Oregon Health Authority's vision laid out in CCO 2.0 for kind of better understanding whether we as the CCO are really meeting our intended purposes in terms of improving the health and experience of our entire communities as well as our members. And with that, I'll turn it over to Nancy.
So as it says, we did take a very unique approach to doing the survey part of the health needs assessment. And we had some partners. We had public health and hospitals, local behavioral health partners who helped us to go through this process. We also had, of course, our advisory councils and our Oregon Health Plan representatives. So in taking the participatory action research model approach, and also we use the popular education model, we were able to have a survey process that was very equity oriented and trauma informed. There was lots of representation from the communities. Everyone understands and knows that how complex, the 80% of health or the 90% of health that happens outside of the doctor's office is. We were able to, in a large geographical region, address that complexity and get people's experiences. And the approach allowed the participant, they shared experiences of health and well-being and challenges. And then they go through and they indicate what that experience meant to them. So instead of someone coming in doing a qualitative assessment or whatever, a researcher coming in and then doing theming and things like that, you know, determining what that experience maybe had meant for the person. The person actually got to do self-code what it meant to them. And the approach allowed, and we were able to collect, you know, both qualitative and quantitative data. So go ahead, Heather.
So where we kind of fit this in is we like a both and approach. We in other areas of our work use more traditional survey methods. And so we kind of like to think of this as like which tool is right for which job. So more traditional survey methods can give a longer term view of healthcare and the social determinants. Other traditional methods, like looking at population health data, can speak to disease state, key community indicators such as readiness or current state. And they can also be subjective depending on how they're defined and sliced and diced, but they can also be pretty consistent from year to year because you tend to be asking the same questions over and over. And they can at times feel like less work, even though they are themselves a lot of work. Person-centered data can be both qualitative and quantitative, but it is very work-intensive. And that work intensivity is because it uniquely centers social determinants and also accurately tries to represent what would otherwise be mutually exclusive. So for instance, we had a lot of respondents who described really challenging, hard times in their lives where they were intersecting with the healthcare system or with community. And yet they would say at the same time that it turned out to be a very positive experience for one reason or another. And so things like that can kind of exist in the same space. It also reduces interpretive bias and can kind of live beyond the survey period in that we can keep diving deeper and deeper and continue to learn from the data that we have. It also drives the way we look at the traditional data. So as I said, we kind of use both. But if we kind of wonder, you know, why is the rate of smoking among this population higher than a different population, we can also go look at those stories and kind of see, you know, what might be kind of behind some of those things at a deeper level. Are there needs that aren't being met? Are there circumstances that kind of play into view? So we can dig deeper into both using this person-centered data. And then it gives a point in time view into the consciousness and values of entire communities once we start to look at more of that high-level quantitative data. Nancy, do you want to talk about the timeline a bit?
Sure. We first started this process actually with our, you know, in the formation of the CCOs, our first health improvement plan. We did in 2014, we did kind of like basically a pilot project where we collected, I think it was a little over 100 narratives from folks in the region. And we also did the more traditional survey as well. And we used that experience to build on with this last go around that we had with doing a health needs assessment. So we started in 2018. We had actually the Transformation Center sponsored a workshop that brought a lot of the key stakeholders together to talk about potentially doing a shared process. We started talking about with our advisory council members, and then we also began to work with a consultant around how do we start to develop the actual survey instrument. So it was a participatory process, and there were a lot of players at the table, a lot of key stakeholders, our health plan members and public health folks working together to create the instrument. We piloted the instrument, and then had a regional plan to get out in the community to collect stories. So that took place over about a year and a half period of time to complete the whole process. When we started the collection, we had a lot of volunteers. It was very labor intensive. and had a lot of volunteers, our community partners, health plan members, CCO staff, going to places like food banks and to our clinical partners let us, like, we went and do it, collected narratives at a dental office and in the hospital lobby and at a, I think I said food pantry, and just various places, community action programs, various places that we thought our health plan members would be. But also this was a whole population approach. We didn't say it was only just for Oregon health plan members. Heather, do you want to take that now? I've lost the PowerPoint again.
Sure thing.
Right.
So as Nancy and I have both kind of repeatedly said, like, this really required a lot of community engagement with our health plan members, but also with community partners, with members of the broader community. And so we wanted to kind of highlight, of the timeline where there was the most kind of intentional community engagement with the process. So as Nancy explained, the story collection questions and prompts were developed with our Oregon Health Plan members as well as community and clinical partners. And then the resulting survey was then piloted in the community in both English and Spanish so that we could get feedback on whether it made sense, whether folks kind of knew what we were trying to ask of them, and things like that, so that we could make sure it all worked. With the help of staff, Oregon Health Plan members, clinicians, community partners, and internal leadership, we collected over 1,252 stories. And they were collected in a variety of places where we knew we could meet, again, not just our members, but really anyone in the community who might be willing to kind of lend us their voice. And so that included places like food pantries, parent meetings at schools, churches, clinics, public health, community-based organizations. And then the community was also part of that theming process. Once you have the stories, you kind of come back together and you review them and theme the quantitative data, but also packets of the stories. And that involved a lot of the same folks who had helped collected and form the survey. So that included members, partners, et cetera, some staff. And then those resulting themes and takeaways were then built into the foundation of what we called our community roadshow. So we took the analysis of those stories, we took data from the stories, as well as population health data, and we went around to 15 different places among our regional communities to kind of get their input on what they would prioritize. And that was how we kind of landed in our main priority areas for this trip and out of this community health assessment.
I want to add too that we offered when we were doing the community collection, we actually gave out a $5 gift card as a thank you for their time, because it isn't, it took like 10 to 15 minutes for each one, and for some people it was, we facilitated it. Some people just did it on their own. We had an app that, someone could just speak into, an app on their phone. We also had it on, we had some iPads and things like that. And then we also had it on our website. And so anybody could come and share an experience on the website. There wasn't a gift card attached to that because we couldn't figure out a way to do it anonymously. And we thought that, and of course we had it on paper, a paper version of it. And we thought, oh, everyone's going to love the app. And we're really excited about that. And it turned out that most people just preferred to do the paper version of it. So there was a lot of that kind of back end of like entering the paper versions into the program, so there were a lot of learnings that came out of the whole process, just that part of it, of story collecting. And then we had a lot of interest internally in our staff who are, who aren't part of our community engagement team necessarily, are like our medical director and folks that, have more clinical work that they do. They were really excited about this and helped with some of the collecting. And that was really, it was a great way for folks to get out in the community and really kind of maybe understand more deeply what's happening in the community. So to have that kind of experience at the community level, when usually a person might be more internal or inward facing to the organization. So, okay.
Yeah. No, thanks. I think the flexibility of that is inherently part of what makes this kind of a unique process. And that actually lends really well to kind of looking at this instrument. This is why we had to have it in multiple versions in order to make it accessible across the board, because it's pretty intensive, actually. So you would start, if you were taking this, we call it a survey, but if you're participating in the instrument, you start here with reading these story prompts and just choosing one that interests you, and then you would be prompted to tell a story based on this prompt. So what helps or stops you or your family to stay healthy or improve health? Describe a specific experience. And they would tell a story, and then they would, after that, give it a title. And then they would start going into these coding questions. And the coding questions are a little bit different from traditional survey questions. And there are a few kinds of them. So this first one we call a triad. They had to be parallel points. So if in this one, thinking about your story, what was important? All 3 points on this triangle all have to either be positively framed, negatively framed, or neutrally framed, so that we can kind of understand what was more true to the person. Or they could, of course, say not applicable, and they would put an X, or if they were on the app, they would drag a little ball to anywhere inside of here. So if they felt like the most important thing, nothing else was important, was access to health education, they'd have it way out here at the corner. But if it was a little bit more like sort of all 3 more equally, it could be somewhere here in the inner circle. And each point inside of this triangle comes with a numeric or geographic assignment to it. So that's where we start to get some of the quantitative data. But it's also the self-coding process, so that I'm not the person deciding that access to health education was the most important thing to them in that story. Then we would do what was called a dyad. So kind of unlike a Likert scale, it was, again, both ends have to be either both negative, both neutral, or both positive, or not applicable, and they could drag a ball anywhere inside of this line. And again, there are numbers assigned to those so that we can do some analysis of them. Then we did also have this additional question that was a written answer, where we asked people to kind of think about the story they shared and think about a vision of the future. Like if it could be ideal in your mind, in your community, what would that look like? And then there were some multiple choice questions, like what type of experience was this for you? Strongly negative to strongly positive or not sure. Some demographic questions, and things like if they were willing to volunteer, what type of health insurance they had, so that we could better understand the community that was represented by the surveys. To analyze, there are actually a lot of really cool things that we can do. So with all of those little geographic points, and we'll see kind of what this looks like in Tableau, but you can do general statistical significance and geographic means. So on this image, what you can see is these dots in the middle of brightly colored circles are what are considered the geographic means. So the average for a certain type of respondent who may have said, if they were answering this question and they said that their experience was very good, this is the average, what was on average most important to them. And then everything inside the circle is part of the statistical significance. So we could start to kind of understand, whether, a specific thing was more important to, say, a group of people on OHP versus not on OHP, or based on age groups, based on demographics, based on how they rate their health. And then there's also this heat mapping here so that we can kind of understand how many dots are layered on top of each other, and each dot is a story. Then we also do theming, where we look at the words of individual stories and try to understand, using a large group of people with different perspectives, kind of understand what's popping up in multiple stories. And then what we call a swim lane analysis, where you look at individual stories, but also the answers to questions across the board and kind of see, like, what is the story of the overall survey telling us for different groups of people. Out of that, and with our community, we landed on some big takeaways together. The first one for our region is that it can be hard to get needs met. And there were a lot of different reasons for that, but you know, some of the big ones are things like transportation or just a service not existing. People helping and community greatly impact health outcomes, or at least self-reported health outcomes. People want to be treated as equals, and it affects health when they aren't, which can be something that's really hard to model, but also seems inherently true, right? And so it was very interesting to be able to kind of see this play out in our data. Difficulties getting around was cited as the biggest barrier, but health insurance and rules that people run into as barriers were also experienced. Housing, transportation, and food were highly needed supports, but so were mental, spiritual, and emotional supports. People need to be heard was really felt deeply across all of our respondents. And then flexibility and predictability are needed. And we kind of summarize this as people really want trauma-informed care, but it was one of the interesting, like, two things can be true at the same time moments for us of people really need us to meet them where they're at, but they also want to know that everything underneath them is stable. All of the rules are going to be the same when they go, that they know who they're going to be talking to, that they know what's coming when they come for help or go for a service. And then in our region specifically, people were really united around strengths and barriers rather than divided by insurance or demographics, though we kind of say that among demographics and insurance, there were more nuanced experiences. So there might be different reasons why a strength or barrier is present that is deeply important to our population. So this is continually popping up in our work. We call this kind of living data, or at least I do and a couple others do, because we are continuing to kind of introduce it into our decision-making process because we really believe in community wisdom and we believe in the hard work that was put into gathering these stories and the stories themselves. So to give some examples of how we're still using this data other than informing our regional health improvement plan, in 2019, the stories and data inspired Nancy actually to propose hiring a senior project manager to launch county-level community trauma-informed networks across our region. And that was really based on that need for trauma-informed care that we kind of saw expressed across our data. In both 2020 and 2021, we also established a rapid COVID emergency fund. And as we were doing that and kind of trying to determine who do we reach out to first, where do we focus, you know, the most weight in terms of funding, we really used what we learned in the community stories and data to think through who of our partners would be the most needed, who were going to be the most critical during lockdown, and also who is going to be at the most risk of closure or other logistical problems due to the pandemic. Because our general assumption was, well, if people are pointing to it as a need before COVID, the need is not going to go away. It's probably going to be amplified. So we could kind of target our intervention. And then continually, CPCCO staff have worked with our community partners to inform locally driven work. So we've used these stories to kind of help underpin work in suicide prevention. We have community partners who have a search grant right now on expanding access to traditional health workers, and these stories have informed that process. But really kind of any partner that comes to us and says, we want to better understand our community, can you help us think through this? We will work through the data with them and pull out some stories that they might be interested in reading.
And it has helped to inform our health-related services, community benefit initiative investments, the framework that we use to, do targeted investment or areas of investment in the region.
Absolutely. And so now, with the time that we've got left, and of course we'll leave some room for questions, we wanted to kind of show you what this data looks like when we're playing with it. So one of the things I love about the way this is set up in Tableau is all of these dots are stories. And if I hover over them, the actual words of the stories are present. So I can look at both the whole picture and I can look at the individual narrative. And so what we look for when we're looking at this data, thinking specifically about a triad, but I'll show you what a dyad looks like as well, is we look for what we call kind of hot spots. So where are there huge clusters of stories? And I might say, how many are in this cluster right here? About 133 out of 1,200. I can also filter down, so I might want to look just at Tillamook County to see if I learned anything a little bit different about the specific needs there. And you can color code stories so that you can also look at things like, folks who are saying that the emotional tone of their story was really positive. Are they all maybe in a different space than the folks who are more on that was a negative experience end of things? So you can read a lot into just one question. Another type of question that we talked about are these dyads. So this is what they look like, and I'll filter this one down a bit, again by county. Let's look at Columbia, for example. And I've still got it color-coded by emotional tone, but now each of these little bars is a story. And again, I can kind of hold the whole and the individual at the same time, which is always really helpful when I want to understand, why is it that most of the negative stories, the orange shaded stories, why are they mostly from here to the right? I can kind of dig into that a little bit. Or what is it over here that really being listened to closely is so positive? Like, what's the outcome? What are the impacts? I can also color code stories by things like how they self-reported their health, which is where we got some of our big takeaways. And so you can really play deeply with this. We can also filter it down. One of the things we'll do sometimes if we're thinking specifically about CCO members is we'll come here and look at just folks who said they had OHP. And some of those multi-choice questions that we use as filters is how often does your story occur, emotional tone, how important they say their story is it something that, there's something that can be learned here, or like it must be heard, there needs to be change. And then of course, demographics. We looked at the demographics from gender, age, ethnicity, language spoken, health insurance. So we really, there's so much here that we can kind of look at and consult, and we're still, kind of actively working on where else can we use this data to kind of change our thinking around an issue, or to really think deeply about what kinds of interventions at the community level might be more helpful. Are there clinical partners who are looking for feedback on certain patient experiences? There's really a lot here to play with. And with that, I think we're open for questions. Thank you, everyone.
Thank you, Heather and Nancy. This is great. Folks, you're welcome to ask a question in the chat or just unmute yourself since we have kind of a smaller group.
This is Gwen Jones from Central Oregon Health Council. Quick question, because I'm not super familiar with this. When you're doing the triangle pieces and you're naming what's on each corner, is that part of the design process or is that prescribed?
Oh, good question. That's actually co-designed. So when we started this, we did kind of an initial workshop with our volunteers, including our members and community partners and clinical partners. And we had them go through a storytelling and sense-making process. And out of that, we kind of worked together to determine what the prompts should be, including kind of the ends of those triangles and those dyads as well.
Thank you.
And then there was a pilot, a small pilot to test out the instrument, and got a lot of great feedback on that. So he brought the group back together to review and update them or modify them.
Can I ask about like a big learning that you had that may have been painful, but really changed the course of the work, that you'd be willing to share for those of us who are interested, but need to know the pitfalls ahead?
It is very labor intensive. And so it's like, it's almost like it felt like times like a military campaign or something, had all the different pieces and, getting volunteers to help collecting and, just even, the gift card and that whole process of having enough of those. And so I would say a big lesson is give yourself a lot of time to prepare it. And, took us, it was a 2-month in the community collecting the narratives, and there were many months leading up to that and months afterwards bringing, having the community events, but also bringing folks back together to look at results and talk about it. The group that designed the help to design the instrument. So very labor intensive and time consuming, incredibly valuable and so worth it. But costly in terms of people's time, and then also the software. We had the consultant, and then the software is called SenseMaker, and the organization we worked with at the time called Cognitive Edge. Yeah, give yourself a lot of time.
Yeah, I would agree. We showed that timeline. We even have said we want more time this time around, and it took us about 1.5 years.
How many, like if you were to put it into like FTEs, full-time employee, or even part-time employees, what would be the range? Like, did you have to hire on to additional staff? How did you make it work and maintain all your regular business?
We have the CCO, we're a line of business of Care Oregon. So we had some Care Oregon internal, like with project planning, some support for that, and it was, part of their job, not their whole job. And then we have internally, Columbia Pacific, wholly dedicated community engagement team, I guess total maybe four FTE, doing all the kind of organizing and coordinating and setting up events and then organizing the collectors, and so.
Yeah, I think our final team, including volunteer collectors, was about 30 people. But obviously, that's on top of their full-time jobs or, any other role that they have in the community. And so it was really kind of a collective effort. And to Allie's question, we tried to have it available in ways that wouldn't be as person intensive. especially because we know privacy was one thing that our community was concerned about. So doing some of these things like in a not so private place, doing the app, that's part of why the paper was so much more popular. But I think it really needs that many people, because folks, either will have questions about the instrument, or they want to do it with you. And then on the back end, of course, like if you're doing it on paper, entering it. So it kind of ends up really we had a lot of help, and we probably could have used more.
The other thing we haven't talked about is that we had this in Spanish, and that was definitely a learning. We worked with an organization to help us have the instrument in Spanish, and but also we went to a community-based, culturally specific organization, and they were like, "What is this?" And we got some pretty intense feedback about like, we don't even know what you're saying in this, so we really had some learnings around, we definitely want to have the instrument, everything in Spanish, to be very, this next time we'll really spend, give ourselves plenty of time to work on it, but also work with folks in the community, not just depending upon an outside organization to develop that for us. And then also collecting the stories in Spanish. In our region, they're just, there's not a lot of organizations that are culturally specific, and so there was quite a bit of just kind of on the ground relationship building to see if people were comfortable with doing collection for us in Spanish, and then actually paying for their time to do that. So to give them like a stipend for their time doing that kind of collection.
Yeah. And thank you. I want to point in the chat to Anne's comment about too much online would have made it harder for some community members to participate. Particularly those who are disenfranchised or elderly. In terms of the minimum number of stories, we, because of the richness of the data, we were told that if we could get to a minimum of 18 stories for any one question in each community, that it would be considered statistically significant, which is kind of amazing when you think about the layers of data that have to be present for that to be true. But it also meant that, getting 1,200 stories, really gave us a lot to play with, a lot to understand and think through. And then to Gwen's question, we did have to change the wording of some of the questions in Spanish. That was actually the feedback Nancy was talking about, was, we got a lot of help in translating it, but not necessarily in transcreating it, so making it feel as if it had always been meant to be in Spanish. And so that meant that there were some clarifications that we had to do on the back end.
These are great questions. Thanks, everyone. Nancy and Heather, I may have talked about this when we met last month, but this obviously gave you at the CCO, it gave CAC members, others participating, an opportunity to interact with other members and kind of get the word out about the work of the CCO and the CAC. Can you remind me if you received any media coverage or anything, or looked into getting that, because it seems like this would be a great kind of story angle.
Well, we did press release, and there was like when we did the community events, there was media at those events. There's, if I remember right, like particularly in Clatsop County, there was a journalist there, and then they wrote a story that was in the Daily Historian, and so we did. And wasn't there, Heather? There was like we did some radio, you know, talking about it, and the regional health improvement plan was adopted by in 2 counties. The county commissioners adopted it as the plan for the county, and then all 3 counties, of course, public health adopted it as their plan. And that was a large part because there was so much, you know, the relationship building that happened, and the degree of communication about the efforts. And
Yeah,
you
I
know,
think,
yeah, go ahead, Heather.
oh, I was just going to say, I think our joke at the time was that we were going to be shameless about it. Like anywhere that we could kind of lift up the process and ask for folks' thoughts, or ask for someone to share it out in the community, we had no problem kind of asking for the plug.
That's awesome. Thanks. So looks like we probably have time for another question or two out there.
I mean, I think it'd be interesting to like we're starting to, like, you know, in 2022 we'll start to plan everything again, to give ourselves plenty of time. But one of the things like thinking about in terms of like traditional health workers and community health workers to you know, figure out a way to enlist and support their involvement in this next go around. I think that would be a really rich, robust way of you know, having people participate in the survey. The interesting thing about this is, like, it's not a one-time, like most surveys you just do one. A person can share as many experiences as they want, and so you can get, you know, quite a lot of, you know, great information from like one area of a community, or even one individual with a specific perhaps health need.
Yeah, lots of lessons learned. And as you say, this is a long, you know, time intensive process, and you start, you finish, and then before you know, you have to start the whole process over again. So.
True. I know.
Well, unless there are any other last minute questions, I think we'll probably close early and give the gift of 10 minutes of time for everyone. Heather and Nancy, I want to thank you again for putting just, you know, all this effort into this work first, and also for taking time out and sharing it. I know everyone is incredibly busy right now. I know that's something we say all the time in these sessions, but I know it's very true. Thanks so much again. And to everyone, again, we're going to be sharing slides from this presentation and the recording. Feel free to share with your colleagues. And I'm going to go ahead and drop a link to an evaluation. Very brief, only a couple questions. If you have time to just share your thoughts, we always welcome hearing them. So Nona, any last comments to share?
None from me.
Okay.
Are all the consultants and software and everything listed on the presentation somewhere?
No, but we can get that for you.
That would be grand.
Absolutely.
Yeah.
Okay.
Thank
Great.
you.
I'll include that in the follow-up. Great. Well, thanks again, folks, and hope you have a good rest of your week.
Thank you.
Thank you so much.